Welcome to Cardiovascular Matters. Whether you are looking for answers for yourself or someone you love, we are here to give you the best information available. Each week, the founder of Cardiovascular Institute of the South, Dr. Craig Walker, and medical device sales veteran Terry Roberts discuss the causes, symptoms, treatment, and prevention of health-related issues stemming from cardiovascular disease. Now here's your hosts, Dr. Craig Walker and Terry Roberts.
Well, hello everyone. Welcome back to Cardiovascular Matters. Our last episode, we talked about kind of the end game, which is critical limb ischemia, and Dr. Walker had just come from the lab where he had tackled two really difficult patients. He and I were talking about, that's certainly something he's faced with every day, but every single day, patients come in and, that may have peripheral vascular disease, and some of them, it's so early, they may not even know it. And what I wanted to do today is have Dr. Walker discuss kind of what he goes through when diagnosing these patients. Dr. Walker?
Sure, Terry. So for any disease, I don't care what it is, the best treatment is prevention. Okay, that's crucial.
Right.
And we know that there are many risk factors for developing peripheral vascular disease as well as heart disease. And those include the following: family history. If other people in your family have peripheral artery disease, you're more likely to get it. Cigarette smoking, very important risk factor. Diabetes. Diabetes really greatly increases the risk of lifetime amputation. Also, high cholesterol and high blood pressure. But if I were to say, what are the greatest risk factors in the case of peripheral artery disease? They are diabetes, cigarette smoking, and advanced stage. This is often a disease of senescence. That being said, I've had to do limb salvage procedures on teenagers in the past that had blocked leg arteries that were diabetic. But nonetheless, typically, this is a disease as we age that becomes much more prevalent. How much more so? Well, there was a trial in the past done in America in which they decided to measure the pressure in the arms and the legs of patients who were over the age of 70 just by having reached that age, or over the age of 55 if they had either smoked or had diabetes. And what that showed was that 29% of those people, 29% of those groups had peripheral artery disease. Now, many of them didn't have typical symptoms. In fact, some had no symptoms at all, but they had the disease process. Now, why is that so important? Well, if one can start early therapy, exercise programs, antiplatelet programs, lowering cholesterol, smoking cessation, we often, in fact, usually could stop that disease from progressing. Right. It's a very, very important thing. And so like anything in medicine, the earlier we can get to a problem, or if we prevent it straight up from the very get-go, we're going to have better outcomes. And it's one of the areas I think we fall apart in American medicine. Our prevention and other things are not as strong as they could be. But then when one comes in to see the doctor, it is important to have the doctor check the pulses in the feet and the pulses in the arms. If there are good pulses in the arms and there are very poor pulses in the feet, then one may have peripheral artery disease. Now, why is this so important? Well, Newman many years ago showed that if we measured what we call an Ankle-Brachial Index, which is looking at the pressure at the ankle divided by the pressure in the arm, if that number, as that number falls below 1, it should be 1, that there's a risk, a cardiovascular risk, a death risk. And in fact, typically by the time people have that number fall below 0.8, in other words, the pressure in the legs is 80% of the pressure in the arms, at 0.8, then typically there are pains in the legs, and typically that person's at a higher risk of going on to have cardiovascular death. How much more so as you make the diagnosis? Many of these people have about as high as a 20% risk of a 1-year major event rate, such as a heart attack, a stroke, or even cardiovascular death. So it identifies higher risk. But now if we measure this pressure all the way down until we get down to the level of 0.4 or 40% of the pressure in the arms, because there are no valves in between the arms and the legs. This is flowing. So that means there's obstruction. When we get down below 4, then the prognosis is as bad as any cancer known to man, except perhaps lung cancer in terms of killing people.
Oh, wow.
So this is a deadly disease. And unfortunately, many people don't recognize it. They either think they're getting old, they think that they've got arthritis when their legs hurt when they walk, but they don't really equate it typically with, I may have blocked arteries. Yep, my dad had them. Yep, my mom had them. Yep, I've smoked. Yeah, I have diabetes, but I'm immune to that disease. Well, certainly that's not true.
Right.
And so picking this up early can help us do the best treatment. The best treatment then is secondary prevention, making sure we take measures to lessen the likelihood of this getting worse and becoming a big problem, but also taking measures at that time to assess, to make sure that that person's not at risk of heart attack, not at risk of stroke, because these are still the leading causes of death in our country. And they're very much linked. If you have peripheral artery disease, these patients with peripheral artery disease have sick legs. And sick legs are almost never attached to healthy people. I mean, that's a very common, very easy theme there. Now, I can't put my finger on a pulse of the heart because the heart is inside the chest. But I can put my finger on pulses in the legs and in the arms. And if those pulses are not there, I've identified a sick patient. And then it's a pretty easy thing to work that up. One can get a duplex ultrasound, a painless test that just uses ultrasound waves, and it gives us images of these vessels and shows us the flow within them. So very important. In fact, aneurysms, belly aneurysms, abdominal aortic aneurysms are a common cause of death with peripheral vascular disease. And aneurysms are most strongly associated with heavy smoking. And so Medicare has actually made it to where if one reaches 65 years of age and has smoked only 100 cigarettes or more in their life, but as low as 100, they recommend getting a screening, either abdominal aortic ultrasound or a CTA to look for abdominal aortic aneurysms, because those are asymptomatic until they rupture. And if they rupture, then you have big problems, because it would be like being shot in a major vessel, and you very quickly lose blood pressure. And when those rupture on patients outside the hospital, a huge percentage die before they ever make it into a hospital. So peripheral disease is deadly. It's common. It's at least as common as heart disease. And much of the problems that we see with it are preventable. So that's some reason we should really look at this. Now, the first test that we typically do if we suspect this, is just simply a measurement of pressure in the arms and the legs. Right. And so we measure it at the ankle, and we measure it in the arms, in the upper arm. Typically, it's slightly higher than the pressure in the arms, but certainly whenever it becomes less than 90% of the pressure in the arms, then that becomes abnormal. And as I've mentioned before, the more the pressure difference, the greater the risk to a patient longitudinally, and the greater risk, of course, down the road of limb loss. Now, not everyone, just because there's a blockage, needs that fixed. You don't go in and fix blockages unless they're going to cause a major issue to someone. So certainly we always try, when we find this, to start conservative therapy. We want to start with the medicines that have been shown to prevent other problems. We want to start patients with a walking program. We work really hard in our clinic to help people quit smoking. Smoking is a real addiction, Terry. In fact, some say nicotine is the most addictive substance known to man on a milligram basis. And people who smoke have a hard time coming off of cigarettes. And it really does take a lot of work to get them off. In fact, if you look at success rates at getting people to quit smoking, they're really fairly abysmal nationwide. And we've been working with a lot of things to try to improve that abysmal rate of discontinuance. We've done fairly well with that, but we're far from perfect now, and I think we have a long ways to go. Newer methods of treating diabetes. Historically, we had an algorithm for how we treated diabetes, but we've just recently had 2 new classes of diabetic drugs that are really showing less risk of big problems. So one class we call SGLT2 inhibitors in peripheral patients are very helpful. They help control the they help to control the blood sugar, of course, but many of the peripheral patients are at risk of going on to have kidney failure. And these medicines have been shown to really lessen the risk of going on to kidney failure. And if these patients are having heart failure symptoms, they're very effective there. The other class, or again, a diabetic class of medicines that have other effects, are the GLP-1 agonists. And the GLP-1 agonists, the ones everybody knows about, are Ozempic and Wegovy, that's semaglutide, or Mounjaro and Zepbound, that's tirzepatide. But these drugs are showing to have more and more effects. So the first effect they proved was that they could lower blood glucose. And that's good. And they lower it in a way that makes it more normalized. In other words, instead of having high highs and low lows, they tend to bring it down into the relatively normal level and stop those big swings in glucose. They also have gotten indications for weight loss because the GLP-1s are very effective in weight loss. They have recently, one has gotten approval, not both, but I'm speaking for the class, what has happened within the class. And different ones had different indications, but they've now gotten an indication for obstructive sleep apnea. They've gotten an indication to decrease the likelihood of heart attack or stroke. They've gotten they have been shown, not gotten an indication yet, but they've been shown to typically lower cholesterol. These are all remarkable findings. And so when we treat diabetes, it's not just that we control a blood sugar, but that we maybe control all the risk factors of that diabetic patient along the same time. Same is true with high blood pressure. Controlling that is very important, and certainly we want to bring that blood pressure to within normal range. But how we get to normal range is important, but also which medicines we use to get there. Some have been shown, once again, to lessen that risk of going on to kidney dysfunction or heart failure or things such as that. And so I think that we have a lot more options than we ever did in the past. But if I were a patient who would go out walking and my legs would cramp at a certain level of walking, particularly the calves cramp, my fear wouldn't be losing my leg. My fear would be losing my life because of the risk of heart attack and stroke. And again, all too often, we don't deal with this. So often we don't make the diagnosis at all in this country. But if we make the diagnosis, historically, then they view it as a sick leg, not a sick patient. And that's an area that I would disagree with tremendously. Those patients should then have a complete evaluation, perhaps at a minimum, a calcium score of the heart where one goes into a CT scan. There is no real risk to it. It tells us if you've got calcium in the coronaries. And if there's a lot of calcium in the coronary arteries, or the arteries that supply the heart with blood, then perhaps maybe some kind of provocative test, like a treadmill test, where you make the heart work a little harder and you look at the electrocardiogram, or some of the nuclear tests would tell you whether or not you're at significant risk of heart attacks. Certainly, we would listen more carefully over the arteries in the neck. And if we hear any bruise, then we would do an ultrasound as well, because that's a cause of stroke. It's not the biggest cause of stroke. The biggest cause of stroke is if someone develops atrial fibrillation. That's the number one cause, and often clots will form in the heart and go up to the brain. But, an ounce of prevention, once you find the diagnosis of peripheral artery disease, is worth a pound of cure. But many people, they don't get all the cramping in the legs. You know why? They learn how to adapt. And I think that happened in my father's case. What he just did was he'd walk slower and slower and slower. And so if you walk very slow, then you may not notice that the legs hurt because you've adapted to let them not hurt by walking slower. When you walk faster, your legs need more blood supply to not hurt. And so all of these things are important. And it's also important about thinking about the pain. By that, I mean the following. Okay, if your leg, if you can't walk very far, you certainly want to think about the problem of peripheral artery disease. But if all of a sudden you say, well, I can go shopping and lean on a grocery cart and I can walk all over with no problem, that suggests the pain is coming from the back, from the backbone, because now you're taking some of the weight off of that area. And so many people can walk just fine if they're holding on to a grocery cart. And so that's one of the differentiators here. Now, all of that being said, some people have peripheral disease and they truly have no symptoms, truly no symptoms. Most, to be fair, have some symptoms, but they attribute it to other things. Okay, but very few, there are some that have no symptoms at all. And just simply, perhaps with diabetes, because you don't feel things as much, your nerves don't work as well. But once again, I cannot overestimate the importance of a good history and physical. Feeling the pulses in the feet, asking the questions about risk factors. That's, I think, the start. And I think if we did that, Terry, we wouldn't just save a lot of limbs. We would save, too numerous to count, lives. I cannot tell you in my career how many people that I found diminished pulses and I didn't have to do anything in terms of restoration of flow in the legs other than medical therapy, but who I found life-threatening heart disease or carotid disease that we were able to treat, that went on to live very long, very successful lives. And I think this is a very, important issue. And that was one lady that I remember very clearly who didn't know if we should do anything with her legs. Her legs were severely blocked because she was 74 at the time. And she says, I've lived my life, I'm scared to do any procedure. And I said, but are you comfortable with your life right now? Because she was having wrist pain. And so we worked on her. And her pains, of course, went away once we restored flow. Very interestingly, I got to dance with her on her 100th birthday. I'm quite certain that may not have ever come had she had her legs amputated at some point.
No doubt. So when patients are presenting, and if the cardiologist is not asking them to remove their shoes and socks, that's something that should take place. Virtually every patient, just check those pulses in the feet and the ankle, and then also in the arms, and that's your starting point right there.
Yeah, I think it's perfectly reasonable for a patient to ask a doctor, could you check my pulses in the feet?
Absolutely.
I think it's a reasonable question. It is that important a screen. Several studies have been done looking at lives saved, and an Ankle-Brachial Index study for which there's a charge is very cost effective. In fact, far more cost effective than routine breast screening for cancer for women. I'm not suggesting we don't do that. Routine breast scanning for women has changed the role. What I am suggesting is we should at least feel the pulses. That costs nothing.
Nothing.
It's part of the initial exam, and that's unbelievably cost effective. But even an Ankle-Brachial Index, which carries a cost far less than the cost of a mammogram, but it does carry some cost. But once again, it identifies a significant disease that can harm people. We have to get rid of the myth that it's just a problem with your legs. It's not. It's a systemic problem when we have this, just like obesity is a systemic problem. We have to change our definitions and how we look at medicine and how we look at sickness in general.
Awesome. Well, like I said earlier, if you're a patient out there, a family member, ask your provider to take your shoes and socks off and measure those pulses, because if you're not doing that, you're not really getting a complete exam, and you're not identifying issues. And like Dr. Walker said earlier, the best treatment for these are to prevent them, and the way you do that is by learning early and taking measures to correct that pathway that's going to take place. You certainly don't want to wait till like the two patients we had today that have been a long time coming, but they end up in a situation where Dr. Walker's taking his day off and going in and tackling these two patients because they were in big trouble with their critical limb ischemia. So again, thank you, Dr. Walker. I thought the great information. I mean, it's just an ounce of prevention is a pound of cure, and patients should really expect to have the shoes and socks off during these exams so they can get evaluated more thoroughly. And hopefully we'll save a few lives here today. So anyway, thanks so much for tuning in to Cardiovascular Matters. Again, it's free to subscribe. Be sure and like and follow us. That way you know when the next episode is presented. Thanks again. Thank you, Dr. Walker.
Thank you, Jerry.
Thank you.
Thanks for listening, and please subscribe, like, and share this podcast with your friends and family. Join us next week for new topics and answers with Dr. Craig Walker and Terry Roberts on Cardiovascular Matters.